All right, good afternoon. My name is Amir Al-Haj Musa with ESAC and Battelle. Thank you for joining this webinar titled Authoring eCQMs Using the FHIR Standard. Today's session will be presented by Crystal Cullum with CMS and Bryn Rhodes with ESAC Incorporated. We'll take a few minutes and just review some administrative notes. Today's meeting is being recorded and all attendees are muted. If you'd like to ask questions, please use the Q&A box on the right-hand side of your screen. We will review questions at the end. After the session, a feedback form will pop up. Please take a few minutes and tell us how we did. We always appreciate your feedback. All right, this is an announcement for the Matt and Bonnie user group. The purpose of the user group is to create an open forum to discuss the status of the tools and gather community and user feedback on planned enhancements and releases. The Matt and Bonnie users can submit questions or topics for discussion using the Matt and Bonnie user tracker, and I'll provide a link to that in the chat window. Registrations for the monthly meetings are emailed to active Matt and Bonnie users, posted to the Matt public website, and also on the eCQI Resource Center. The user group meets the third Thursday of every month, typically at 2 p.m. Eastern, though this month, the April user group will be held at 3 o'clock today, directly after this webinar. There is a link to the registration for the April session, and I'll also place that within the chat. And now I'd like to turn the presentation over to Crystal to review some background slides. Thank you.
Thank you, Amira. The agenda topics for today are welcome and background, quality improvement, QiCore for electronic clinical quality measures, quality data model or QDM versus QiCore, specifying measures with QiCore and clinical quality language, QiCore and CQL specification example, and next steps. Just to offer a little background, here we have a representation of the changes to the components of eCQM specification with the move to FHIR. In the top left, you can see the specs currently contain the quality data model, or QDM, the clinical quality language logic, CQL, and the health quality measure format, or HQMF. With the move to FHIR, QiCore replaces QDM for clinical data. The FHIR Quality Measure Implementation Guide, or IG, replaces HQMF for eCQM structure, and the CQL logic would remain the same. Below this is a representation of the changes to eCQM reporting. Again, the QiCore profiles are replacing QDM. The DEQM measure report, individual and summary, replaces QRDA 1 and 3. The goal is to align quality measurement standards for eCQM development and reporting using FHIR. And now I'll turn it over to Bryn Rhodes to review the presentation.
Thank you, and thank you for attending. So to start with, last presentation, we talked about FHIR, introduced the notion of implementation guides, and specifically for this presentation, we're going to go deeper into QiCore as an implementation guide that contains a set of profiles intended to be a conceptual model or an information model for quality measurement and decision support. Those profiles are based on US Core and the base FHIR resources and used for quality applications in general. The quality measure IG then is a specification IG detailing how electronic clinical quality measures are structured. So how you use the base measure resource in FHIR to express quality measure specifications. So to start with, digging into QiCore, quality data model has categories and data types and attributes as a conceptual model for the representation of clinical data. You combine categories like medication and data types like active or administered, and attributes like relevant period and the medication code using a value set to identify the kinds of data that you're looking for and combine all those into a QDM element. Within QiCore, the category and data type roughly correspond to the type of resource. And for each of those, we've got a profile or sometimes multiple profiles that represent those data elements in QiCore, and then provide a mapping from the QDM to the QiCore profiles. The attributes correspond to elements in the FHIR resources, and the category and data type are the resource and often a status element that is important to capture the what happened aspect of a QDM data element. So QDM versus QiCore as a comparison, QDM is a data model containing the information needed for quality measurement. It's focused on quality measurement. It's a conceptual model, and it's currently used within the eCQMs to represent data elements. It's maintained by CMS for that use, and it is updated by the QDM user group and a governance process associated with those changes. QiCore is an HL7 implementation guide that defines the FHIR profiles for quality improvement. It has input as far as requirements for that model from the quality data model, but also from other quality applications like decision support. It's heavily informed by QDM and is maintained by the HL7 Clinical Quality Information Work Group, regularly balloted and updated as part of the governance and change management processes associated with HL7 as a standards development organization. QiCore profiles are constrained by elements such as status and intent. So an encounter has a status of in progress or completed. Medications have medication requests, for example, have intents for things like whether it's a plan or a proposal or an order. And one profile may address multiple QDM data types. So it's often the case that the mapping for multiple QDM data types will result in reference to a single profile. The other direction exists as well. Sometimes the QDM data type may map to multiple QiCore profiles. The QiCore profile, for example, medication request represents the QDM data types for immunization order, medication active, medication discharge, and refills on a medication dispense. So QiCore scope, this is a snap of the first couple rows of the index for the QiCore profiles. So on the left is all of the QiCore profiles listed. In the middle is if there is a US core profile corresponding to that usage, we derive from that, and we'll talk more about what that means. And then on the right is the base resource on which that profile uses. In particular, we have some negation profiles, and we'll get into that more as well later. Where possible, though, we derive from US core to make sure we're aligned with vendor implementation and standards there. So QiCore profile compared to a US core profile, you can see they're largely similar in presentation. This is the differential view in both cases. And so you can see what you see in that differential view is the elements of the QiCore medication request profile that are constrained or otherwise modified by the QiCore profile. And on the right, you can see the elements that are constrained or modified by the US core medication request profile. So we build on that profile and introduce any additional constraints that are required. In this case, mostly it's about ensuring that your references are to other QiCore profiles. So the differential table is only showing for that specific profile what is different between it and either the base resource on which it's defined, or in the case of a derived profile, the difference introduced by the specific profile. So it's only going to show things that are different between the medication request, the US core medication request profile in this case. So the red flag indicates an element that must be supported if present. The cardinality indicates how many must be reported for the element. So your cardinality is the required. So status, for example, is a required must support element. The type defines the type of data within the element, and where it's kind of grayed out, that means we've not changed that from the base. So QDM to QiCore mapping navigates similarities and differences such as those with medication request and provides a detailed mapping of all the QDM data types and attributes to QiCore R4 resources, profiles, and elements. So I'm going to walk there real quick and just show that. This mapping, this is the currently published mapping. There's an update in progress, but in general, you can find the QDM data type along the side using the contents index. And then for every type, you can see a detailed discussion of, for the attributes in the QDM context, what that maps to in terms of the R4 overall profile and the specific elements, along with any notes about the usage there of that mapping. So here's an example of medication request. This is in that link that we just sent or just provided. In particular, the comments provide discussion where it's not a one-to-one universal mapping where you need to apply constraints. For example, in this case, the medication discharge active would be represented in QiCore as a medication request with a status of active, completed, or on hold, and constrain the category to community. So here's a medications on discharge example. This is from 104v9, discharged on antithrombotic therapy. The width here includes a medication discharge for pharmacological contraindications for antithrombotic therapy, where the author date time is during that relevant period of the stroke. And pharmacological contraindications in FHIR is represented then as a medication request, where that medication is in the pharmacological contraindications for antithrombotic therapy. That's the same reference to a value set there. Where the category is community or discharge, and the status is active or completed, and the intent is order. So the statement about medication discharge carries with it some status information about what that event is that you're looking for. And that status information is important to represent in the FHIR translation of that using the status and intent. That's one of the key aspects of that mapping is to provide that information as a guidance about how to select that information as you're mapping QDM data elements to QiCore. Here's another example from the cervical cancer screening, cervical cytology within 3 years. Laboratory tests performed for PAP test where cervical cytology relevant date time is 3 years or less on or before the end of the measurement period. And there's a result. The mapping to FHIR there includes the status of final, amended, corrected, or preliminary. So there's consideration about status for that observation, and the effective ends 3 years or less on or before the end of the measurement period. So relevant date time of a laboratory test performed maps to effective. We use this normalized interval because effective can be represented in multiple types, and that gives you a consistent interval-based representation of that timing. And then you can use the timing phrase, the same timing phrase, 3 years or less on or before. So another aspect that QiCore introduces is extensions. These enable identifying additional concepts, things like actions not performed or procedures associated with encounters, elective procedures or conditions present on admission. These are aspects of the quality data model that are important for representing some of the existing eCQMs that don't have representation within US core, and sometimes even in the FHIR resources themselves. So in those cases, we have defined some extensions to support describing those elements. And if you go to that extensions page in QiCore, there's a listing of all the extensions. And then for profiles that use these extensions, they're listed as elements in the profiles that use them. So one of the key aspects or important representations in eCQMs is the ability to understand why something was not performed. Inequality measures ask for these specific reasons that things were intentionally not performed. For example, antithrombotic not given at discharge. The medication request for antithrombotic therapy with no antithrombotic discharge do not perform is true. And the reason code is in medical reason or patient refusal. So there are several negation profiles that are defined specifically to support these types of data elements, where we capture the status, the expected status, the flags about the do not perform, and the bindings to reason code elements. So there's a listing there of all of the not done profiles. So looking at, for example, device not requested, we have the extension for the do not perform reason. So the underlying device request resource doesn't provide a way to say that. So we've added that capability there. We've also introduced the do not perform as the underlying resource doesn't have that element. Importantly, this is a modifier element. So that means that systems cannot ignore that information. A modifier extension it's an error for a system to see a modifier extension and not understand it. So in this case, it's critical information about this device request. It determines whether we're talking about a request to do something or a request not to do something. And in this case, then we bind the do not perform reason to those negation reason codes. It provides a way to represent not only that we didn't, that something was not performed, but that what the reason for that was. And these negation reason codes have the set of allowable values for those. And those are mapped to value sets in the value set authority center as currently defined in the eCQMs. So you can see there are several of those. Those cover the set of negation patterns that are currently used throughout the eCQMs. So next, we're going to dig in more detail in that example measure, CMS 124, cervical cancer screening. So we'll start by looking at the currently published eCQI or eCQM on the eCQI Resource Center. It starts with the human readable description, the metadata information for the measure. And then the human readable is organized into population criteria, the definitions and functions, the terminology, and the data criteria, supplemental data elements, and risk adjustment variables. So we start with the population criteria overall, the initial population, denominator, exclusions, and so on. And then we provide the listing of definitions that are used in those. So cervical cytology within 3 years, for example, is defined here as a laboratory test performed in the PAP test value set. Once we go through those definitions, then you get to the terminology. So these are all of the codes and value sets that are referenced anywhere in this measure. Then the data criteria. So that's the QDM data element combined with the value set that is used. So this is taken together the total data requirements for this measure. And then the supplemental data elements and risk adjustment variables. So looking at, this isn't exactly the same measure, but similar. This is rendering of the FHIR translation of the measure. The narrative is still being improved. but in general, it follows the same pattern. You've got the data requirements. This is the listing of types and associated value sets that are needed to satisfy the data, the terminologies that are used, the supplemental data elements, and the overall metadata for the measure. We also introduce some FHIR-specific things like the related artifacts. This is inclusive of the terminology and other libraries that are referenced. And then we go through the logic definitions, where we provide for each definition used in the measure the CQL expression. Again, that's a kind of work in progress, but just to show the FHIR rendering of a similar measure. So next, we'll go through in more detail the kind of line by line translation of this. So we'll start with the initial population, where we're looking at patients between the ages of 23 and 64, female, and have had qualifying encounters. Where qualifying encounters is any of the encounters performed in those associated value sets during the measurement period. So the representation of that in FHIR, this is the source for the library. The initial population is that the gender is female. The calendar age in years of that patient's birth date is in that same interval from 23 to 64, and that the adult outpatient qualifying encounters exists. This adult outpatient encounters is referenced from a library because it's the same qualifying encounters that are used across multiple measures. But that representation includes the same value sets. So it's encounters where the encounter is finished. It occurred during the measurement period, and it comes from any of those same value sets. So it's a very similar representation. The biggest difference is the encounter performed needs to reference that status element in order to make sure that we're talking about completed encounters, because the encounter type or the encounter resource in FHIR can be used to represent encounters in different statuses. All right, so that's the initial population. And then the denominator is the same as the initial population. The exclusions are that the patient is in hospice or has evidence of hospice care, or exists evidence of absence of cervix. And that absence of cervix is that there's been a hysterectomy performed in that value set before the end of the measurement period, or there's a diagnosis of congenital absence. So in the FHIR rendering, again, a reference to has hospice, effectively the same expression, referencing from the hospice library, or exists the absence of cervix. And that's represented in the same way with a procedure, hysterectomy with no residual cervix, where performed ends on or before the measurement period, and the status of the procedure is completed. Again, that procedure performed versus the use of a procedure that can represent procedures in different statuses, or the diagnosis, in this case, a condition resource is used. The condition congenital absence of cervix starts on or before the measurement period, and this is an exclusion, and so all statuses are acceptable. All right, and then digging into the numerator, cervical cytology within 3 years, or an HPV test within 5 years for women aged 30 or older. So looking at the numerator there, cervical cytology within 3 years, or exists, and so it's exactly the same. And then the difference is in the definition of those elements, specifically the observation Pap test with cervical cytology. Again, the status is important to reference, and the use of the normalized interval to get to a consistent timing, and 3 years or less on or before the end of the measurement period. And then the HPV test observation, where there is a value and the status is in final and it occurs when the patient is at least 30, and it ends 5 years or less on or before the measurement period. So that test, effective, the patient was 30 test. All right, so very similar representations, one using QDM and one using FHIR, and informed by the QDM to QiCore mapping to determine which resources and profiles to use. So just reviewing current activities, CMS began converting QDM-based eCQMs to use FHIR in the spring of 2019. So that's been in progress for quite a while. CMS program measures continue to be tested at HL7 Connect-a-thons. There's one coming up in May, actually. We're continuing to do this testing. Measure authoring tool and Bonnie, the measure testing environment, have been updated with FHIR functionality. And there's a measure repository that contains draft content for work in progress eCQMs and example expressions. So that repository is actually the source where some of the work that has ended up in Connect-a-thon testing, as well as some of the ballot content examples. eCQM conversion of program measures to FHIR is ongoing using Mat on FHIR. Planning for ballots and updates. The data exchange for quality measures, which is the implementation guide that submitters use to report on quality measures that are defined with the quality measure IG. That was validated in September 2020. Updates are being applied there, and it's very close to publication. Quality measure IG is being balloted in the May 2021 ballot, specifically introducing support for composite measure capabilities, refined measure narrative, and description of data requirements. It's also introducing important terminology capabilities, specifically the ability to describe stable expansions of the value sets used in different release years of the measures. So there's a good chunk of that ballot that's new, that's talking about terminology service. There's also knowledge repository capabilities that are discussed in the quality measure IG ballot for May. And then QiCore is currently based on the US Core fall 2021 planned update. We plan to, when US Core updates in the fall of 2021, currently plan to update QiCore to follow that update. There's also an errata that's coming to introduce QDM version 5.6 mapping to continue supporting this ongoing translation effort. And HL7 convenes these Connect-a-thons 3 times a year, January, May, and September. Coming up is the May, and then we'll plan to have additional testing in September timeframe as well. So resources to get you started. Current FHIR measures are on GitHub at that link. They're FHIR R4 standards and implementation guides. This is all using the currently released version of FHIR, the mixed normative trial use R4 with errata applied, .0.1. The current build of FHIR that will change, but you can see as we gain implementation experience and those changes result in changes back to the FHIR measure and measure report resources in the base specification. And if you look at the current build, you'll see some of those have already been are already starting to be applied in the base spec. So you can see the measure in the current build is actually has introduced some new elements. There's the US Core currently published R4 version that QiCore is based on, and the DEQM current version published August 2020 and the quality measure IG, current version published February 2020. There's also the Clinical Quality Improvement Resource Center FHIR education page, which has lots of additional educational material, trainings, tutorials, those kinds of resources there. And resources to get you involved. There's collaborative learning. We host a monthly Cooking with CQL, QDM, and FHIR, where we bring up examples. If you're interested, feel free to submit examples for review on that session. If you're interested in participating in the standards advancement process, the implementation guides and FHIR resources are stewarded in the HL7 Clinical Quality Information Work Group. There's a link to the page there, and that work group holds weekly calls as well as some subgroup calls that this work is being performed in. And of course, participation in the HL7 FHIR Connect-a-thons. And there's a page on the Resource Center where we've gathered those resources together for the FHIR Connect page. All right. So that's the material, and encourage questions and discussion at this point.
All right. We are now in the Q&A session. Reminder that the slides for this presentation, the link for that is in the chat. So there's a lot of links and good resources within those slides, and you can grab that from that link. There is a Q&A bubble at the bottom of your screen, and feel free to type in your questions there. We'll start at the top from the most, the first question that came in. It looks like QiCore profiles that overlap with US Core Profiles medication request, for example, have differences in what elements must be supported. How are those deviations decided upon?
So mostly based on the needs from quality improvement perspective. For example, the US Core medication request indicates dosage information should be provided, but it doesn't go any further than that. It doesn't provide any detail about how you provide that dosage information. And that's one of the areas that we need more specific information about. Part of doing calculations like cumulative medication duration and when the medication was applied or when it's expected to be consumed. Those all have the CQL that references those elements needs to be able to be written in a way that expects the data to be present. So the profile provides information to implementers about the way that the measure expects the data to be provided. And that process goes through, one, the need to express that, and then two, discussions with groups like the pharmacy work group that are stewarding the resources for medication request to make sure that we're using those elements in the way the resource intends, as well as Connect-a-thon experience to make sure that the vendor implementation of those profiles results in correct application of those. So that's where most of those deviations are discussed and decided, where a need is recognized either from QDM or from additional development happening in the FHIR space. And then we work with groups like cross-group products for coordination with US Core Profiles and the individual work groups stewarding the resources involved to, one, make sure we're using the elements correctly, and two, try to align that with vendor adoption.
Thanks, Bryn. The next question we have is, will QiCore completely replace QDM as a human readable format, or is it in addition to it?
Yeah, so QiCore replaces QDM as the model for measure developed in FHIR. So from the standard stack perspective, it's a total replacement, but it's the evolution of those standards, and there's no, at this point, timeline about when that happens. So from the standards perspective, we're ensuring that we can support specification of measures completely in the FHIR stack.
Okay, we'll skip down a little, and there is a question in the Q&A. What's the difference between medication request, medication in value set versus medication request and value set?
So that's a feature of CQL, where for a given type, there is for a given type as defined within the model, the model can specify a primary code path. So there's no code path here. So this laboratory test performed is indicating that the primary code path is code. But let's say I wanted to use something else like the result. I wanted to look at laboratory test performs where the result code is in a particular. So I can put result in. So that's the difference in that medication request with no code path there is relying on the default specification from the QiCore model info, where it's saying the default lookup for medication request is by code. So that's explicitly saying I want to use the medication code path to do that terminology resolution. Does that help?
I believe so. If you have any follow-up, yep, she said thank you. Yeah. All right. Next question is, will measure specs be available in both the format as in QDM as well as FHIR, or just the FHIR?
Again, that's about timeline. I'm not totally sure, but I imagine that would be a possibility.
Okay, more to come on that then. Next question we have is, will attribution and reporting levels be expressed in CQL?
So this conversation has been happening a lot in the FHIR space, especially with the data exchange for quality measures and the gaps in care support. The notion of attribution in eCQMs is, I want to say, not expressed entirely. It's kind of intentionally left out, other than a few key things like qualifying encounters, for example, that try to give information about attribution. But the attribution model in general is not specified by eCQMs, specifically because there are program variations in how that attribution works. So the measures themselves try to stay out of that question as much as possible. That specifying it is possible in FHIR, but for the same types of reasons, the measures themselves are typically silent about what that attribution model looks like, so that multiple attribution models can be used to inform. From the perspective of the measure, you're talking about whether a patient clinically or from an administrative perspective applies. And the attribution models can then be layered on top of that. And there are lots of discussions within the Da Vinci space about the use of the Da Vinci attribution implementation guide, as well as within gaps in care for how the care management coming out of gaps in care reporting can be effectively applied and routed to the appropriate providers. So I think that it's likely still the case that FHIR-based eCQMs will not specify that attribution model, but there are a lot more possibilities for computable representation of various attribution models in the FHIR space.
Thank you, Bryn. Next question we have is, can you talk about ensuring alignment with library data requirements with CQL?
Yes, for that, let me pull up this. So if you look at the library, and I'll just walk through this example in particular. So if you look at the library for breast cancer screening, it has these same types of things, right? The data, the dependencies, the parameters, the data requirements, the same content is reflected. But in the case of a particular library, this is reflecting the total data requirements for every expression defined in this library. So the initial population qualifying, and only the data requirements defined in this library. So things that are referenced in shared libraries, for example, are not specified within the library resource. So what you get when you look at the data requirements and content from the perspective of a particular library is all and only the things that are talked about in that library. But when you go to the measure that uses that library, this is the effective data requirements computed by looking at the expressions that are actually used by this measure. And so it's not the sum total of all the data requirements for any library that's used. It's only the elements that are actually referenced by the expressions from this measure. And so you won't see data requirements for expressions in shared libraries that this measure uses, but doesn't actually call those expressions. In addition, from an alignment perspective, we're using the same structures to represent this information in the measure resource as we do in the library resource. And the data requirements operation is how that information is calculated.
Okay. I think there was a follow-up from the question, computed from CQL. Is that what it means?
Yes, that's exactly what it means. So we specifically take in the measure resource. Let's just look at the XML here. So the measure resource is specifically saying, sorry for all the scrolling. There's lots of narrative, so I have to get past the narrative. But the measure resource is specifically saying, I've got there, now we're into the, okay. My population is, the initial population is referencing the initial population expression in this library. And I'm talking about the numerator, the initial population, the denominator, and so on. We literally start with just those expressions and we trace each of those expressions following the CQL and only gathering the set of requirements that are referenced by those expressions. So that what you get is an effective data requirements computed from what's actually referenced by the measure. Does that make sense?
Yes. All right. Next question we have here, I think we have time. If an organization with FHIR data uses US Core rather than QiCore, how can they most effectively compute eCQMs against their data?
So the measure will specify details that could be reported from US Core, but if only US Core is supported, measure elements other than those built off of US Core may not be as easy to retrieve. So there may be a gap. If you run a measure against a system that only supports US Core, then the elements that are referenced by the measure that are specified in QiCore may not be present in the data that's returned from that system. And if that is if there's required data, for example, then that would result in a validation detection when the data is submitted. So the data is validated against those FHIR profiles, and if QiCore requires some piece of information because the measure is expecting it, then that would be a validation issue.
All right. Just looking through to see if there were any other questions that we skipped. We do have about 5 more minutes in case anybody would like to type in their questions. And to answer your question, Bren, yes, it did make sense to the requester. I think those are all the questions within the Q&A box. All right, I think we could close out this session. I want to thank you, Bryn, for presenting, and thank you everyone for joining us today. We hope you enjoyed the discussion. There will be a feedback form following the close of this webinar. As a reminder, please take a few minutes and leave your feedback, any questions you have. And thank you again, and have a great day.